Welcome to The View on GU, the place to be for translating uro-oncology knowledge to action. Here are your hosts, Drs. Aly-Khan Lalani and Christopher Wallis.
Hello and welcome to The View on GU. I'm Chris Wallis. Along with me today is my co-host, Aly-Khan Lalani, and we're very lucky to be joined by Dr. Frédéric Pouilot from University of Laval. Aly-Khan, how are things? We're getting ready for the great migration south to Vegas.
Yeah, against the grain, heading to Las Vegas this weekend. So I think our listeners and viewers will get our take live from AUA and hopefully unimpeded, crossing the borders north and south. And, certainly really happy to focus on prostate imaging today.
Absolutely. So Fred, thanks so much for joining us. We know that you're sort of one of the Canadian leaders in driving our thinking about advanced imaging and prostate cancer. So thanks so much for taking the time to join us today.
I'm very happy to be here. Thank you for the invitation, guys.
Absolutely. I think we've had a real revolution in imaging and prostate cancer, maybe over the last 10 years, if we take a bit of a wider scope. While I was a resident, and I guess that applies to you as well, we essentially were in the trust for local evaluation and CT and bone scan for more distant evaluation of disease. And now we have so many more tools in our arsenal. Maybe just to sort of level set for us, can you talk a little bit about what we mean when we talk about molecular imaging? What's the terminology? What are we talking about? And how does this fit into the picture of prostate cancer evaluation?
That's a great question because we use the molecular imaging sometimes for non-molecular imaging when we think about MRI. And basically, molecular imaging implies that we are looking at tumor metabolism or antigen. We're looking within the cells. We're not looking at the anatomy like we would do with conventional imaging by planar CT scan or MRI. And that's a huge difference because when we're looking at a CT scan or an MRI, we're looking at the difference in size or the change in the anatomy on the three axes to really diagnose cancer, for instance, or inflammation. While with molecular imaging, we're looking into cells. We're having tracers to look at the pathological or physiological process within a structure. And that's a huge difference. We're not looking at just the anatomy, but we're looking at really the biology of what we're looking at. It could be inflammation, infections, it could be tumors.
Yeah, so to think a bit more broadly, I guess, we've been using molecular imaging of some kind or another for a long time. A technetium bone scan, I suppose, falls into that category. But more recently, we've been talking about PSMA-based molecular imaging. So can you walk us through the basics of it, of how this works, how it helps us, image and localize prostate cancer?
Yes. So molecular imaging mostly use two different detection modalities. You can use SPECT CT, like bone scans, and you're looking at beta particles. And you can use also positron emission tomography or PET scan that can be fused to CT scan. So it's CT scan. So it's PET CT. And that can detect photon emitted by the isotope. So those are the two basics apparatus that you could use in the clinics to do molecular imaging. And then comes the tracer. The tracer is the small particles that you can inject intravenously to the patient that will travel throughout the bodies and go into every organ and be retained within the cells or bind to an antigen like PSMA. So when we talk about PSMA imaging, is the ability of such tracer to go throughout the body and bind specifically the PSMA antigen. This antigen is a transmembrane protein called prostate-specific membrane antigen. So basically, if we try to wrap it all, you have this tracer you inject into intravenously to a patient, the PSMA tracer. It binds to where you find the PSMA protein. And because this tracer is linked to an isotope, that will emit photons, you will have the detection of the location of PSMA expressing cells at some sites where cancer is by the PET apparatus. And that can be done as well with SPECT/CT, but with less precision and less sensitivity. That's why we use mostly PSMA PET-CT instead of PSMA SPECT/CT.
Got it. And that's a clear distinction. And we did in our previous episode with Catherine Zukatinsky talk a little bit about the different tracers and what's coming down. And so we might get to that later, but let's start maybe around the indications piece. So in your practice and, thinking about not only national approvals, but perhaps international at a high level, when would you suggest that, PET imaging or PSMA PET imaging is kind of mission critical or mostly indicate? So let's talk about initial staging, who should get a PSMA PET versus conventional, and maybe then lead into a little bit about BCR, the biochemical recurrence, and when that would be indicated. So take us through a little bit about indication of PSMA PET in your practice.
Yes. So where you practice is very different. I think if you're in the US where you have full availability for any PSMA PET CT scan you would order, I think you could use it everywhere from high risk prostate cancer staging at diagnosis to a biochemical recurrence after radical prostatectomy or radiation therapy, and even as a biomarker for radioligand therapy, PSMA radioligand therapy. At least in Quebec, we don't use it as widely we would like to do. I think there is an indication to use it everywhere, but because of the availability, we would use it for very high-risk prostate cancer at staging. So those that are at very high risk of having metastasis and to fail primary therapies to see if we should change our primary modality. And for BCR, biochemical recurrence after primary treatment, and especially after radiation therapy, if we're trying to do salvage procedures like salvage prostatectomy or salvage HDR or brachytherapy, high-dose brachytherapy after radiation therapy. And then there are different circumstances where you might have several cancers. You're not sure which one progress, and because PSMA might help to differentiate prostate cancers from others, sometimes we use PSMA for that purpose. Mm-hmm. And the last indication I wanted just to discuss, and it's probably that's the strongest one with the highest evidence of impact, is to use PSMA as a biomarker of response to a PSMA radioligand therapy. If I had to choose one indication, that's the one I think I would pick up in all the possibilities, because we know it has been studied, the impact in phase 3 trial, and we know also how radioligand therapy in castration-resistant prostate cancer can improve overall survival. So not a clear question, but guidelines, if you have the possibility to use PSMA as much as you want, it's better than conventional imaging. You should use it for staging intermediate, high risk, and very high risk prostate cancer and patients that failed primary therapies before undergoing salvage therapies.
Absolutely. I think that's a really helpful landscape. For what it's worth, in the Ontario context, for local staging as an upfront staging modality, we can do it for anyone with a PSA over 20, anyone with clinical T3, and those high-grade histologies. So those are our local indications. And I'm wondering, if you had your druthers, you could do anything you want. Is there any patients you would choose not to use a PSMA-based initial staging approach before local therapy?
That's a good question. Which one? For sure, if the risk of undergoing of finding metastasis is very low. The other question we have to ask ourselves, if we find a metastasis, because we know that PSMA will find probably either lymph node or bone metastasis in 25% of patients on top of conventional imaging. But if finding metastasis doesn't change your management, let's say that you would give still radiation therapy and ADT in a patient that is very high risk, and a patient has already chosen that approach, why trying to find those metastases in this patient? Because PSMA PET CT, not PSMA, but local radiation is indicated for both low volume metastatic prostate cancer, as well as high risk prostate cancer that will undergo radiation therapy. So in that particular case, I'm not sure I would request PSMA, even if the patient is very high risk.
I think it's a
for
great
the reason
point.
I just stated.
Yeah, it goes back to our some of the teaching in medical school, I guess, right? Is only order the tests that are going to change your management, not just because it's available as a cornucopia. But I guess maybe the logical follow to that question, I was going to ask it in a slightly different context before, but is how do we reconcile potentially differing stages or representations of disease when PSMA PET disagrees with our conventional imaging? So the typical example is PSMA PET finds more disease than our conventional imaging has. But I'm sure if you ordered enough scans like I have, you find somewhere that actually goes the opposite direction. There's a questionable lesion on a bone scan. You do a PSMA PET and it's actually non-avid. And it actually brings us back the other direction. I think Dr. Hope and others published it out of ASCO a year or two ago, the false positive rate of conventional imaging that could be resolved with PSMA PET. So I think we see it in both directions. And I'm wondering your approach on how you sort of adjudicate those disagreements.
I think some misunderstanding about PSMA is that it is very specific, more than sensitive. So if I had to use PSMA, let's say that I would have like 10 scans to use for staging in a year, I would use it more to ensure that oligometastatic prostate cancer is really a metastasis, to ensure that single lesion is not a false positive. As you mentioned, all the studies using conventional imaging are showing that conventional imaging has a false positive rate on bone scan of 20%. Okay, that's a lot. One patient out of 5. And that brings the concept of confirming a metastatic patient rather than finding new metastases. And as you mentioned, it goes both ways. But most clinicians would think that molecular imaging is better to find metastasis rather than confirming a metastasis on conventional imaging. And that's a very interesting different use of that specificity that is found.
Yeah, and I think it's a great point because even within PSMA PET, Fred and Chris, I'm sure you guys have talked about this in tumor boards, but for the indication you mentioned, Fred, for currently Pouliot, but hopefully in the future other options as well, we are having even PSMA PET performance. There's some PSMA avid or less avid lesions above or below blood pool or liver, and I'm starting to get reports suggesting an FDG PET to sort out the discordance. Even though vision criteria would not have per se required that, whereas other trials did. So I definitely take your point between conventional and novel, and then even within the novel, in any one individual patient, the disease state matters and what you're looking for matters, and then how do you break these ties? Because I think we're talking about high-risk local or low volume that might get some SBRT elsewhere over and above what you're doing to the prostate, but even getting access to radioligand therapy with PSMA less avid or negative disease in a patient who has some avidity, I'm finding more and more we're being asked to break the tie with an FDG PET. And so, I feel like this whole imaging theme is why we wanted to have this conversation, because I think it's going to be more and more, if not confusing, I think nuanced, right, than before. So, definitely appreciate that this will be a space we'll need to follow.
And then just
go ahead.
For the question, also the restaging is very complicated. How do you use this positive vending? Where you do place it into clinical trials? We all do that every week at our tumor boards, trying to figure out where do belong that patient that had negative conventional imaging, then where we found molecular imaging M1A or M1B. M1C is pretty rare, but sometimes you find lung disease where we're confused with that. And I'm not sure anyone has any answer to that. And that's a big confounder. And when we were discussing, when I do not ask for PSMA PET CT. It's mainly where it will complicate rather than help the patient. Yeah. Basically, even though if I find metastasis, I don't know what to do. I don't have any evidence. And that's where I will still use conventional imaging. And for metastatic prostate cancer patient, once we know they are metastatic, most of them I will use conventional imaging for that reason. All the evidence for treatment change benefits are based on conventional imaging.
Yeah, and just to finish that point, because I agree that also gums up our tumor boards is if you treat someone and call them now metastatic on novel and not so metastatic on conventional, I mean, it's a big prognostic conversation with the patient. And now you're obligating to lifelong therapy. So if we are perhaps overcalling or let's say escalating a little bit of care where conventionally you wouldn't have needed it, I think it does behoove us to say, can we scale back after a year or two? Because taking that person and doing lifelong treatment, I can tell you, I mean, they may be undetectable for many years, but things will add up toxicity-wise. So, no, I think this is why we should be thinking more about the novel imaging guiding our next trials.
Absolutely. When we
agree.
So I guess maybe the corollary to that, and maybe it's implied in your answer, is if you were to do a PSMA PET up front, someone you presumed was high-risk localized, and you found metastatic disease, do you follow it up with conventional imaging thereafter to ascertain stage, or do you just act based on the PSMA PET-based metastatic disease?
So at upfront staging, usually I would not go back to conventional imaging because of the specificity of the PSMA PET CTs. So if the patient has, let's say, a bone metastasis, I think it's more reliable than would be conventional imaging. And then we must bring into our decision, in my opinion, without evidence, as I've mentioned, other clinical characteristics, such as PSA doubling time, the PSA value, the Gleason score, the age of the patient. And then you try to find the best window of evidence that we have with our clinical trials using conventional imaging. And you try to make your patient fit in one or the other evidence we have. And we know we're imperfect, but I don't think that we should use molecular imaging per se, just as itself, as it stands, as a staging only. You need to bring other important patient and pathological characteristics to make your decision, your imperfect decision.
Absolutely. Thank you.
Yeah, I was just going to ask, we didn't get into it in too much detail, but from where you sit right now and looking at the landscape, do you see any pitfalls of particular tracers we should be aware of as we think things moving forward? Has the field harmonized around one, or because you've mentioned some limitations about what novel imaging as a whole can do, but if we get down to the tracer, should we be getting into that granular detail, or do you think there's more similarities than differences amongst them? What's your take on that?
Most FDA approved, I would say, tracers are considered pretty equal. And I would talk about the PSMA 11 that is linked to gallium-68, the DCF-PYL that is bound to 18 fluoride, and the new RH PSMA 7.3 that is linked to 18 fluoride as well. And these, at least for staging and looking at histopathology of lymph node dissection in prospective multicenter trials, have very, very similar sensitivity and specificity. And they're considered equal. The RH PSMA 7.3 has less renal excretion. So if you want to look within the prostate or around the prostate, that might be one that be more helpful. However, the Lighthouse study has shown that this tracer might be a little less sensitive for lymph node metastasis. So that's really the difference, but most nuclear medicine physicians would consider these three tracers almost equal. And there is this PSMA 1007 that is bound to gallium as well, and that has been reported with less specific I don't know how much it is used elsewhere in Canada or in the US, but I'm not sure there is any broad use in the world right now because of the advances made in terms of clinical trials and approvals for the three others I've just mentioned.
Absolutely. I think, your comment about the GU excretion maybe fits really well back into that biochemical recurrence space when we're thinking of local failures and really being able to evaluate the prostatic fossa or the residual prostate. And so when we're thinking in that context, how do you think about when to pull the trigger for imaging? I feel like there's the inherent tension I find in my clinic, and maybe you're just smarter than me and have resolved this, is that the radiation oncologists want to give salvage radiation in a prostatectomy patient on the early end. And yet the yield of PSMA imaging improves as we let the PSA ride up. So when is too early to order a PSMA PET in a biochemical recurrent, say, prostatectomy patient to start? We can talk about some radiation failure patients as well, because they also fail from time to time. But maybe, on the prostatectomy patient, when do you think about pulling the trigger and balancing that, getting a yield out of the PSMA PET, but not losing your window for early curative salvage radiation?
So then you need to bring the clinical factors, I think, to really discriminate a patient for which you absolutely want a PSMA. You might be ready to wait because you feel, or you have all, based on mammogram, the argument to think that this patient is metastatic. Let's say the patient had a very high-risk prostate cancer, the final pathology at radical prostatectomy, his ISO 5 had a PSA of 30 before, and negative margins, and then you have a detectable PSA immediately after your surgery, and you have positive lymph nodes. Let's say that's the worst case, but that's a patient you need a PSMA. You don't want to radiate blindly to this patient, and you have a PSA of 30, so you might catch up something somewhere. So that's a patient I feel it's systemic, detectable PSA after such a surgery. That patient need to be, if you want to consider early salvage radiation therapy, you need a PSMA at some point to ensure it's not metastatic, and maybe wait if you don't find it because of the sensitivity issue at low PSA. We might think that the metastasis has been missed. So that's the patient we would go for PSMA PET, absolutely, and I would be maybe ready to wait a little bit to ensure the patient is not metastasis. On the other point, you have a patient that have 80-90% chances based on mammogram to have a sustained response to salvage radiation therapy. Why are you doing a PSMA in this patient? Why you might find a false positive, as we have mentioned, and you might harm the patient by not giving him radiation, or create anxiety for a detection rate or a detection node that is just at the limit, is just an overcall and will not change anything. And that patient that has very high yield of responding, I will not PSMA that patient like blindly. I would radiate beforehand.
Right.
And I think we should use nomograms before making decision. That's what I do. I try to decide, and even the patient that have, in my perspective, a very low response to salvage radiation, I calculate the odds, the chances that he would have PSA recurrence free at 6 years with the Memorial's Sloan Kettering nomogram, and discuss with the patient. Most patients, even though they have only 20%, they would like to have salvage radiation therapy. So incorporate the nomogram, try to predict the value, the added value, but also the harm. You can harm your patient if you find this non-specific lesion and change your management.
Yeah,
I don't know what you're doing, you guys, for these threshold level. If you use a clinical data to guide your indication, or you just do it blindly. It's much simpler to do it blindly, honestly. But then you're cut with what you find, right?
Yeah, and I have a general sort of similar practice to yours, but I get lots of questions about, should we do a PSMA PET when the PSA hits 0.1? The residents will show up in my clinic. What about a PSMA PET at 0.1? Sort of indiscriminate. And I think, as you highlight, there's opportunities for, personalization of care, not with very fancy biomarkers and AI-based tools, but just very simple, clinical factors, pathological results from our prostatectomy specimens that can help guide us on that decision making.
Yeah.
Sorry,
go ahead, Fred. I was just going to say that, on our end, from a medical oncology point of view, but certainly when we're seeing all these cases in tumor board, yeah, I agree. Like, there's a lot of patients coming in that might have standardly gotten a treatment, and these PSMA PETs are being done, and we're all having to hear and discuss and think through it at tumor boards. So I agree with you. You do wonder about harm, and then it gets into whole upstaging and what are we doing thereafter. So,
and we have to keep in mind that when you look at the best studies, prospective studies, looking histopathology of lymph node dissection at staging, not restaging, but staging, the sensitivity of PSMA PET CT compared to the lymph node dissection histopathology was only 30 to 40%. So we miss so much metastasis in the end. At some point, when you're at PS of 0.1, the chance that you will really change something to that patient if he has high yields of responding to radiation therapy is very, very low. And oftentimes we mix the data. We would say probably 25% of the patient will have a lesion on PSMA PET at the PSA of 0.2. That's it. That involves also the detections within the fossa, the prostatic fossa, that you will radiate anyways. So that we have to discriminate and differentiate detection rate and metastatic detection. And the numbers we have in mind are detection rate, not the metastases that are found. And that is something we need to educate the residents and ourselves and think about when we're ordering these scans.
No, it's a great point. And as we turn the corner and just close this episode, Fred, maybe your final take on what you're excited about in terms of the future of prostate imaging, where you see it going, and then even if that expands beyond prostate cancer. I know you have interest in novel imaging and other GU cancers. Maybe just take us through some future research interests or things you're keeping an eye out for.
But for sure, it's the incorporation of all these new tools we have with other clinical factors we've just discussed. So now there are more and more data about the inclusion of the molecular imaging staging with other clinical factors to predict outcomes. And hopefully trials will come to really guide us with these very important novel tools, which is molecular imaging. The other very important aspect, I think, of molecular imaging that needs to be explored is the dynamic molecular imaging, where you can, because it's not classical staging, you have an uptake that you can quantify with SUV max or SUV mean or whatever. You can take a baseline value, treat the patient for a couple of weeks, months, or whatever, reimage, and then see how the metastasis or the primary cancer behaves. So you really interrogate the biology of the tumor, and that might be one of the best biomarker we never had, looking at the tumor itself, how it responds beyond PSA, beyond and looking at polyclonality. A lot to develop and a lot of excitements about using also dual tracer to see differentiation from prostate cancer, adenocarcinoma to neuroendocrine, and repeat these imaging to follow this differentiation. I could continue for hours about, but the radiomics, the AI development, and the integration of all this information, not only at one time point, but through the treatment stage of prostate cancer, and using AI to integrate all that, I think we will do medicine very differently.
Yeah, and I agree. I think it's going to expand beyond prostate, as you say, too. There's some interest in how we're doing novel imaging or alternate imaging in certainly kidney and other cancers too. So Lots to talk about, and I agree we could go on and on. But for now, we'll say, Fred, thank you so much for joining us. And to our listeners and viewers, don't forget to rate, review, subscribe. Let us know through our socials what else you'd like to listen to. And on behalf of my co-host Chris Wallis, I'm Aly-Khan Lalani. Have a great rest of your day, and you'll hear from us next at AUA.
Thank you, guys.
Bye now.